know that around 50 to 20% of postpubertal males have a condition that could impact their fertility. It's called a varicocele, and it happens when the veins in the scrotum become enlarged, usually on the left side. But why does it happen? Varicocele occurs when the pumpiform plexus of spermatic veins become dilated. It typically appears on the left side, often develops during puberty, and can grow larger with time. The left internal spermatic or gonadal vein is one of the longest veins in the body, entering the left renal vein at a perpendicular angle. The intravascular pressure in the left renal vein is higher than on the right because it's compressed between the aorta and the superior mesenteric artery coming off the aorta above the renal vein, thereby producing a nutcracker effect. This phenomenon causes increased pressure in the left gonadal vein, which can dilate and cause incompetence of the valve leaflets, leading to retrograde flow of blood towards the testes, resulting in dilation of the scrotal venous complex. In clinical features, a varicocele is diagnosed by its characteristic physical findings, which range from minimal left-sided scrotal fullness on Valsalva monover to a large, soft, left-sided scrotal mass known as bag of worms that decompresses and disappears in recumbent position. Varicoceles are graded 1, 2, or 3 according to size. A varicocele may be asymptomatic or present with any or all of the following, like dull, aching, scrotal pain, usually on the left side, that worsen while standing and improves when lying down. Atrophy of the left testicle believed to be secondary to loss of germ cell mass by induction of apoptosis or programmed cell death initiated by slightly increased scrotal temperature. And that can lead to decreased fertility. In diagnosis, if there is uncertainty about the diagnosis based on physical findings, a scrotal ultrasound can be performed for confirmation. While there is no standardized ultrasound technique, evaluation typically includes examining the patient both lying down and standing, as well as at rest and while performing the Valsalva maneuver. A diagnosis is confirmed when any spermatic vein measures 3 mm or more in diameter. Testicular volume should also be measured. Normal volumes range from 20 to 24 milliliters, and volumes below 20 milliliters have been associated with subfertility. In further evaluation, abdominal imaging to detect thrombosis or malignancy should be considered for patients with a new onset or non-reducible varicocele or a moderate or large-sized varicocele. Varicoceles usually occur in the left hemiscrotum due to left gonadal vein anatomy. Bilateral varicoceles occur in 33% of patients. Unilateral right varicoceles are less common and were previously considered associated with acute malignancy due to obstruction or thrombosis. However, a retrospective study of over 4,000 men with varicoceles, including 8% with isolated right varicocele, showed no difference in cancer diagnosis based on laterality. Therefore, routine abdominal imaging of patients with isolated right varicocele to rule out malignancy is no longer recommended. Varicoceles are often identified in infertile men. 40% of men with primary infertility are found to have a varicocele, and that number rises to 75 to 81% of men with secondary infertility. However, 75% of men with a varicocele are fertile and 80% have normal semen parameters. In a World Health Organization study of over 9,000 men who were partners in an infertile couple, a varicocele was much more common in men with abnormal semen, 25.4 versus 11.7% with normal semen. Many different mechanisms have been proposed to explain the link between varicocele and impaired spermatogenesis. A multifactorial etiology is likely, involving increased testicular temperature from reflux of blood, oxidative stress, and adrenal catecholamine reflux, and androgen deprivation. This subtle increase in intrascrotal temperature induces apoptosis of sperm-producing cell within the testis. Now let's talk about management. Most varicocele do not require intervention. Adolescents and young men with a varicocele and objective evidence of reduced testicular size on the affected side may be offered repair. Treatment options include surgical ligation or percutaneous venous embolization. Low microsurgical approaches result in fewer recurrence and complications compared to high non-microsurgical approaches. So the evidence is limited and of low quality, some studies have demonstrated improvements in semen parameters over 3 to 6 months and fertility following varicocele repair. Painful varicoceles are treated with surgical ligation. Typically, varicocele pain consists of dull, aching, left testicular pain, then standing, and disappears, then recumbent. Subclinical varicoceles are defined as those that are discovered on Doppler ultrasonography but are not palpable on physical examination. Surgery or venous embolization is not recommended in this setting, as studies have not shown statistically significant improvements in semen parameters or pregnancy rates. Then varicoceles are palpable on examination but are not associated with pain. Management is determined by age. Young men with varicoceles should be evaluated for testicular hypertrophy on physical examination. Patients who are postpubertal should undergo a semen analysis if acceptable to the patient. Further management depends on those results. For patients with varicocele and testicular hypertrophy or abnormal semen parameters, the algorithm suggests surgical ligation or percutaneous gonadal vein embolization. Research indicates that surgery enables catch-up growth of the hypertrophic testes, and this return to normal testicular size correlates with restored fertility potential. One study found that 83% of children and young adults experience increased testicular volume after varicocele repair. In patients with bilateral varicoceles, both testiculars will be smaller than normal. In those patients, a lack of growth during puberty may assist with the detection of testicular hypertrophy. If the semen parameters and testicular size are normal, algorithms suggest monitoring with semen analysis every 1 to 2 years. If abnormal semen parameters develop, surgical or percutaneous intervention should be offered as above. If the patient above the age of 21, algorithms suggest monitoring those patients who desire continuing fertility with a semen analysis every 2 years. In such patients, abnormal semen parameters may warrant surgical intervention. For patients who are no longer concerned about fertility, minor scrotal discomfort can be managed conservatively with scrotal support and non-steroidal anti-inflammatory drugs. Surgery, which is the preferred treatment option for varicoceles, involves ligation the gonadal vein branches so that retrograde blood flow can no longer reach the plexus of veins in the scrotum. This procedure can be performed with inguinal, subinguinal, or retroperitoneal approaches. Some urologists favor laparoscopy or microsurgery, which may have a lower recurrence rate. Percutaneous gonadal vein embolization, with or without sclerotherapy, is an alternative to surgery. However, it carries a risk of serious complications, including vascular perforation, coil migration, and thrombosis of the pumpiform plexus. And recurrence rates are higher than with traditional surgical approaches. So that's it for today. I hope this video helped you understand this topic better. If you find it useful, don't forget to like, subscribe, and hit the notification bell so you don't miss the future videos. Let me know in the comment below what you think or if you have any questions. Also, don't forget to follow me on Instagram for more useful educational posts. Thank you for watching, and I'll see you in the next one.